today regarding COVID-19 and health. Just get our slides up there. There we go. Sorry, technical glitch. Just a small technical problem. I'm just going to have to leave and sign back in. If I leave, Alana, will that cancel it all? Okay, I'll sign back in 1 second. Okay, good day, students. Apologies for the little technical detail there. We've had multiple programs going. Thank you for joining today. See, we have a number of individuals. And I thought that as we're continuing to work through our course, that I would spend a bit of time with you going through a few aspects of the COVID-19 situation and how that plays into public health and a lot of what we're learning, particularly with regard to your chapter with regard to the public health system, governmental public health, which we discussed and had a lecture on previously, and we'll be coming up to talk a little bit more about public health preparedness also. So you're living through now with the COVID-19 really what public health was supposed to be preparing for very well. We can discuss how well the country did that. But this pandemic really is illustrating a lot of key issues. So let's go through a few things about COVID first of all. This is the total number of confirmed cases of COVID-19 globally since the beginning of, or January 21 here, and you see different curves, epidemiologic curves for the number of cases for the world, and then the United States and 3 different countries, China, Italy, and Spain. And there's something quite striking, and this goes through April 7th, so that's just through about last Wednesday or Tuesday. And what you can see here is that something quite striking. The United States is on a different pattern and a different curve than the other countries here, China, Italy, and Spain. And the main reason for that is that these other countries are further along, and earlier in the course of their efforts, they implemented strong shelter-at-place quarantine, social distancing efforts, very rigorous, and they've been able to sort of bend and limit the peak number of cases and flatten these curves here for China for sure. In fact, you probably heard last week, after 76 days on shelter at home or very stringent quarantine in parts of China, they released those restrictions based on not having a large number of new cases each day. This is the total cases. So you can see it had been flat for quite some time. The United States is still on a uptrending exponential curve of total COVID cases, whereas Italy and Spain have begun to flatten. If we extend this now a few days, the curve is actually flatter, and you see that Italy and Spain have begun to feel the effects of their shelter at home, quarantining, and social distancing programs. This is a great website for you, Our World in Data. I would encourage all of you, you want to look up data. There's a lot of data on COVID. There's a whole section on COVID, but there are many other topics there that would be relevant to public health and also to many of your other courses. So I would encourage you to explore that website. It's quite well done. Now, this shows the daily number of new cases in these countries, and it's based on a rolling 3-day average of new cases. So this talks about the number of new cases each day. And you see here that February and early March, there was not that many new cases, but then all of a sudden began this exponential climb. This is what happens when the infection becomes or overtakes the ability to contact trace, to identify, isolate, control individuals with this infection. And I'll explain the reason for that in a little bit more detail in a bit. But you see that, again, the US really took off, and we're up here now to a large number of new cases daily across the country, much more than in these other countries. These other countries, Spain, Italy, Germany particularly, and of course China, have been able to flatten their curves, make them peak and plateau or bend that curve, not follow this exponential pattern like we have, because they implemented rigorous restrictions and quarantines and social distancing programs further back some weeks ago. We're now really just starting to see, after a couple of weeks, 2-3 weeks or so, the effects of the social distancing and the shelter-in-place orders that have been given by various governors and others. And you see that we've actually been able to blunt this peak and begin a downswing in the number of daily new confirmed cases. This is very encouraging. This is what we want to see. This is the goal of these interventions. And of course, what we're wanting to see is that this curve to continue declining way down before we begin to roll back the shelter in place and the various programs that limit businesses and movements and events and so forth. Okay, but there is encouragement that we begin able to bend this curve at the top. And we'll have to continue these efforts to bring this down to a lower number. Now, the number of deaths from coronavirus is shown here. Now over 70,000. It's now over 100,000, I think, worldwide. And you see that these curves, the US is still climbing up here, and I think we've begun, when we add another week to this, approximately, we've overtaken Spain and Italy in terms of more deaths. The deaths will lag, so while this curve will bend earlier, if the measures we've taken are effective, the death curve may take longer time because it takes time for many people who are infected for the disease to run its course in those individuals. Well, this is the timeline of COVID-19 in Oklahoma specifically. I just wanted to review this with you. February 24, 26, at the time when the United States had 35 confirmed cases with no deaths. we saw the first case in the United States with no known exposure. That meant that the first COVID case occurred in a person who had not traveled to China or Italy or any of the other countries where there was a known epidemic underway. The first case in Oklahoma happened over March 7, 8, by which time more than 100,000 cases were globally in over 100 countries. The president declared a national emergency on March 13th. On March 15th, Oklahoma had a case. It was its third or fourth or fifth case, which occurred in Cleveland County, so very relevant to the university. And this was the first case of community spread to be documented in Oklahoma. What this means is that this case had no history of exposure or travel to any affected area. That was the item that the Governor Stitt was waiting for before he declared his emergency declaration. So when that happened, he immediately moved on that and brought in some restrictions and actually strong recommendations for social distancing, for curtailing businesses, various other things in the 19 counties that had cases at the time. Of course, one can debate whether this is the best policy because people travel between counties, number one. Number two, individuals, as I'm going to show you, who have no symptoms or are pre-symptomatic can transmit the infection. And so traveling between counties because something you want to do is closed in your county, a restaurant or a hair salon or some other service, had the potential to move, of course, the virus between counties. But that was only for a few days. And March 24th, the governor's Safer at Home order was issued, which include all counties, and this goes through April 30th. So we have a bit of ways to go, 20 more days. As of yesterday at 9:30 p.m., the United States had now more than 500,000 cases with 22,000 deaths. This death proportion you should know as the case fatality rate, and that is based on all of the data, 3.9%. The probability that an individual who is diagnosed with COVID-19 will die as a result of that condition. Oklahoma has 2,052 cases as of last night at 9:30. I'm sure this has increased further. 100 deaths. Our case fatality is a little higher than what we see here nationally. This could be influenced, both numbers could be influenced by relatively limited testing for the virus in the United States. So we may be seeing only the more serious cases, but this has been pretty consistent. The other big contributor may be that Oklahoma's underlying health, population health, is less healthy than many other states. And so we may be looking at a higher rate. When we have a high rate in our population of hypertension, of cardiovascular disease, of diabetes, and of lung disease, these are the risk factors that when you add COVID-19 on top of that, places a patient at a very high risk for death. The higher rate of those things in our population means we're likely to see a higher case fatality rate. The distribution of the cases is spread over the counties with the largest populations. As you see here, they have the most cases. And then the rest of the cases are spread across almost all counties. I don't think there remains now a county without a case. There might be one, but I was looking for that and I saw a case there yet the other day. So I think every county has a case now, at least one. But this drops off. There are 6 or 7 counties that have about 50 to 60 cases, and then it drops down quickly and to lower numbers. It may be that the rural nature of Oklahoma will protect us a little bit because the spread of the virus is related to population density, as you see how many cases New York had, and you saw how fast New Orleans developed the cases. But let's underscore one point. It's back here. Here, we have only 35 cases in the United States. In the span of about 7 weeks, that goes to over 500,000 cases. This shows you how highly contagious and transmissible this virus is, and underscores our crucial efforts to control it. And you see that Oklahoma, in the span of a month, went from its first case to more than 2,000 cases. Again, highly transmissible and infectious virus, very important. This is a good website if you want to follow the progress of COVID-19 in the United States, for all states, and even within states it can break it down into counties. Then coronavirus.1.3acres.com. This is a good website. It's updated every day, at least once a day, if not multiple times a day, to keep you on top of what's happening. Now this slide shows an important concept. This shows seasonal influenza flu cases in Oklahoma and influenza-like illness in Oklahoma for 2017 to 2020. So these curves plot the percent positive of flu cases, or the number of flu cases, positive flu tests from emergency departments and doctors who report this data to the state health department. And what we see is that this is a typical pattern for the flu season. And let's just follow the red line, which is this year's flu season, November 19. We see towards the end of November, beginning of December, sharp uptick as the flu seasons take hold. These are confirmed cases of flu. We see that continues through January and into February, peaking at around late February, early March. And then the number of confirmed flu cases presenting to these healthcare facilities drops off rapidly. You see that here in the red circle. Okay, and that pattern was consistent for the last 2 years, the green and blue lines. This is seasonal flu. We get an uptick at the beginning of this in late November, progressing through to about the end of February, early March, and then a decline back down to almost nothing through spring and summer and early fall. Now on the right-hand side here, we see the percent of flu-like illness. So these are people coming to the emergency department or other doctors' offices with flu-like symptoms, but not confirmed flu. And here we see that for the last 2 years, the green and the blue lines, that the flu-like illness reports mimic the pattern of confirmed flu. You see the curves look very similar here, okay? Again, upticking at end of November, December, peaking end of here a little bit January, February, and then coming down. But this year, the red curve, in February, we began to see a decline in flu-like illness, flu-like symptoms presenting. But then, towards the end of February, we saw a tick back up like this. This is the coronavirus, which has symptoms very similar to flu. And you see that although flu cases continued to decline and went down in the usual pattern here to April, that flu follows, we see flu-like symptoms, fever, cough, sore throat, shortness of breath, other symptoms increasing and continuing to present to our healthcare facilities. That is due to the coronavirus. Now, for this to happen here in late February means that the virus must have been circulating in our population at least 2 to 4 weeks earlier, because it has an incubation period of 14 days, so up to 14 days. So really in February, this virus was here somewhere in the population in Oklahoma and led to an uptick in this illness, flu-like illnesses, which we now know was due to COVID virus. Just to review how COVID-19 is transmitted, and it shows here that an infected individual releases aerosol droplets of greater than 5 microns in diameter when they talk, sneeze, or cough. And these droplets can travel. It was thought that they would travel under a distance of 1 meter, So if you're close, they can travel in the air, through the air. They can be landing in the mouth or nose or be inhaled by a susceptible individual who's within that distance. Research that's just coming out from the CDC suggests, in fact, that the coronavirus droplets can travel up to 4 meters. This is very concerning because our social distance, 4 meters is about a little over 12 feet, and our social distancing is looking at 6 feet as the space that we have to stay in. So we need more study here of that, but generally it's thought that these droplets are going less than 6 feet and more around 3 to 3.5 feet or 1 meter. Now, in addition to these aerosol droplets with virus being inhaled or landing in mouth or nose of an individual, they may land on a surface that you may touch. Your mouse for your computer keyboard, your phone, the door handle, your car door, door handles to buildings, on and on and on. And you may then touch those, and then if you touch your face, that is a potential way that people inoculate themselves with the virus by transmitting it from surfaces. And we know the virus can last quite some significant time on plastic or cardboard surfaces or various other surfaces. And finally, close contact with family members, loved ones, others, where you're living in close quarters, again, may lead to indirectly transmitting these viruses through these same mechanisms. So that's COVID-19 through aerosolized droplets. That's different to measles and tuberculosis, which are airborne transmission, meaning that these are smaller particles in the air which travel farther than 1 meter and can be recirculated, for example, on the airplane. The CDC has documented transmission of tuberculosis that way. Fortunately, we don't think we're in that type of a transmission mode right now, and our social distancing efforts may work. Of course, if we knew this was the case for COVID, we'd need to take even further measures. But this approach of aerosolized droplets greater than 5 micrometers or microns is the current thinking about the transmission of COVID. Now, the epidemiologic pattern of COVID is shown in this slide. This is just a schematic which shows the period of time that individual is infectious, with the distribution here being more infectious and then less infectious as time goes by. This is time on the horizontal axis. Now, the virus has an incubation period of 2 to 14 days. That means that from the time of infection to the onset of symptoms of the disease, of the COVID infection, is between 2 and 14 days. However, the median is 5 days, which means half of the patients will develop symptoms in 5 days or less, and the 97th percentile is 11 days. So 97% of patients who get exposed to COVID-19 virus will develop their symptoms by 11 days. The problem is something we call the serial period. The serial period is the time from which one individual is infected, so the time that I may be infected, to the time that I would first infect somebody else. So that is the period between which the virus will move to a new host. Time that an individual is infected to when a next individual is infected. That is 4 days, which is less than the incubation period to the onset of symptoms in more than half of the people. So individuals can become infected, and during this period of time, they can be, without symptoms present, they can be transmitting virus to other people. Some people will become infected, transmit virus, and never develop symptoms at all. Those are called asymptomatic. These people who are contagious and shedding virus and infecting others during the incubation period this period of spread is called pre-symptomatic spread. That's a technical distinction for infectious disease epidemiology, but essentially the important thing is that people without symptoms can be infected and spreading the virus, and that's crucial. We mentioned the case fatality rate. We don't know how long people remain infectious with COVID. That's very important. So once you have got COVID and the disease has run its course, you seem to be getting better, how long will you continue to be shedding the virus? Here is a crucial point, because we want to bring these people back into work, back into school, back into their functions in society, but we don't want them to be released back into the general population if they're continuing to infect other individuals. You've probably heard a lot about laboratory testing in the media and in your reading, and it's very important. Our ability in this country to test for COVID-19 has been very, very limited by comparison to other countries that were dealing with COVID-19. And in Oklahoma, it's been very limited. So we're near the bottom in testing per capita historically. This is changing just over the last 10 days. But up to then, we were in the bottom of testing amongst the country that was near the bottom of countries in testing. Well, a lab test for the virus only indicates a snapshot at a single point in time. It doesn't tell you that you won't become infected in the future. It's just a point in time as to your status with respect to the virus. There are two types of tests: the genetic test or molecular test called the PCR, polymerase chain reaction, which many of you will be familiar with from your genetics and other courses. And there is a test in blood or serum for the antibodies that are produced by our body in response to COVID-19. So these two tests are different. The PCR measures the presence of viral genetic material in the sample obtained. And this is usually obtained by swabbing the nose or the mouth and getting that material. And then if you're doing the PCR to see if there is viral material, in this case RNA, because COVID is an RNA virus, if you can measure that material. A positive test means the person is infected. They have the virus. They may not necessarily have symptoms yet. The positive test can precede the development of symptoms. This is a way then that we can identify asymptomatic individuals early in the course of infection. And this could be, if we have it widely available and are able to test extensively, a very valuable tool to curtailing the infection, to identifying infected individuals and isolating them, which is the hallmark of how we control infectious diseases. We identify all the infected people, asymptomatic and symptomatic. We then isolate them and we contain the infection. The problem we've had with COVID is we've not had enough testing to test widely to also isolate asymptomatic individuals or minimally symptomatic individuals. A negative test means there is no evidence at the present time that the person is infected, but a single negative is not dependent on in people who we know have symptoms and COVID diseases. We want to have 2 negative test days apart before we can clear those people and say it's okay for you to go back to work or back to your school or back into your regular routine. Now, the antibody test measures the presence of antibodies in the blood to the COVID-19 virus. A positive test means that the individual was exposed to the virus weeks or more previously, at least 1 week, if not usually more, 2 weeks or more previously. A negative antibody test does not rule out current infection. A person may be infected and just beginning to produce antibodies. And regarding a positive test, we don't know the extent of immunity this confers. Is it okay for this person then to be exposed in the future? And will they be immune from future infection with COVID-19? We don't know. We hope that this condition will behave like many others, where antibodies will confer to you appropriate immunity in the appropriate concentrations in response if you have a robust antibody response. But we have to establish that this virus could be different. It has a number of differences. So from the point of view of public health measures to control the spread of pandemic infection, the inability of the United States broadly to test widely early in the course of this growing infection. That means early back in February, when we had less than 35 cases. If we had been able to test aggressively a large number of people, the contacts and the various people around those 35, and had we been able to test them, even if they did not have symptoms, and isolate them, we likely would have been able to control this pandemic much better. Instead, since we didn't do that, the virus became, and let me step back, the other countries were able to do that. And the best example in the slides here was South Korea. And you see where they are, the daily number of new cases, they barely had too much, and they were able to keep that daily new confirmed cases at a very low number down here, almost on the x-axis, unlike these other countries where there was a growth in the viral presence in the community. And South Korea did a very aggressive testing and isolating and quarantining of the population. And that was successful in limiting COVID spread into their population. Very important, because this was a concern. Now what we've had to do, because we didn't do that hallmark of identify the infected, isolate them, and contain them, we end up having to shelter at home, the vast majority of the country, almost 300 million people, instead of the smaller group that we could have isolated had we had the appropriate testing and have much less impact on the economy. So this really illustrates that the preparedness, the ability of our organizations like the CDC to develop and launch this test quickly, or the ability of private laboratories to step up and do this in a timely way, happened fairly quickly once there was pressure and funding put towards it late in the game. But early on, we really dropped the ball in our testing capability by comparison to other countries who were able to use that to their great advantage in curtailing the epidemic. So coming back, what we wanted to be doing is, when we see these cases here, March 7, 8, when Oklahoma was in the range of a few cases each day, had we aggressively tested a big swath of people around that time, all the contacts, remember the testing was of limited availability, so the only people who were getting tested were people who had symptoms. But it's the people without symptoms who can spread the virus to others. And we would have needed to test back in this time frame, late February, early March, and we may have been able to blunt or stop this serious curve going up here. That's something to always keep in mind. Early intervention with that type of approach is always the hallmark to controlling these new unknown infectious conditions. So with that, I'll leave those slides, and then I'm looking here, let's put the, stop sharing. No, I want to show me options. I'm looking for the chat box here. Let me stop sharing for a moment and go to chat. And now I see that we have a couple questions come in, and that's terrific. So question was, as the curve flattens, does it give us a good prediction to when things will start to open up? And that's in fact That's the whole point. You've got the gist of this. You know, not only at the flattening of the curve, but really the key parameter as to when we can begin to open things up more will be when the number of new daily new cases, when that comes down to 0 or a very low level and stays there for at least 1 incubation period, if not 2. We really need to see that number of new cases come down to 0. So if we go back and look at the slide set again, and we just see that here to the question, we want to be able to at least, you know, we want to bring this number of new cases way down here at a very low number or to 0 and keep it stable for a long time. So that's a great question. Excellent question. Do we think a national, Jill, great question. Do we think a national shelter in place would have been more effective than state governed? Yes, because some states didn't do it, right? Florida, the governor didn't act until very, very late, and you saw all the people on the beaches on spring break. So we could have prevented that. And had we a national shelter in place early, that could have very much been helpful. But there's been variance in how aggressive some of these governors have been in their efforts. And you probably read, there was an article recently about San Francisco. The mayor there took very aggressive steps. She implemented a shelter-in-place order before they even had 1 case in the city. So she was very much on the ball, understanding the nature of this infection, the importance of the asymptomatic individuals. And if you look at where San Francisco is for a similar populated city, they really did prevent a big impact of cases on their city by doing that. So yes, I think a national one would have helped. Do I think there is a chance that classes in the fall will be online only? I am hoping that we will be able to get back to regular classes in the fall, Catherine. I think, but we can't promise it yet. This was a long call I had with President Harris and his team earlier this morning, and we were looking at what would be the conditions and basis by which we would do that. What we would want to see is we would want to see that the number of new cases in Oklahoma, specifically in Oklahoma and in Cleveland County, but in Oklahoma as a state, is dropped down to either 0, the number of new daily cases, down to 0, or a very low number, that we can control them by testing and contact tracing all the contacts of a person, symptomatic and asymptomatic. If we see that these cases are, number of new cases is down to a very low level and is stable and has stayed there for a period of time, 1 to 2 incubation periods, which is 14 to 28 days, then we hope we can resume at least some in-person activities and more normal function than just totally online. So that's the hope, and we'll work towards that. This is a debate, Advil and Tylenol. I am aware of some of the readings of this. I think that people are avoiding this out of some clinical observations. And so Gracie and Maddie, ibuprofen is, Advil is the trade name for ibuprofen. Ibuprofen is a generic name. They're the same thing. So these medicines, you know, are of a concern. I would go to the CDC website and look there as to what medicines they recommend for you if you need to take a medication. Now, regarding masks, I think it's a good idea. I think our messaging has been wrong about masks from the very beginning. The messaging at the beginning was focused more around the N95 mask and the need to, because another big error in our national preparedness was the lack of this personal protective equipment and not having enough of these masks. And so the N95s were really needed for healthcare workers to take care of the patients who are coming in with COVID. And we didn't want people running to get N95 masks and wearing those routinely, such that there would be no supply to take care of the sick patients. That was specifically about the N95. I think that the messaging wasn't clear. Some of the public didn't distinguish between N95, for example, or a surgical mask. And then there was, I think, messaging that was confusing, that a surgical mask doesn't help, don't wear it, all of those things. I think that we put masks on cancer chemotherapy patients, for example, to prevent them from getting infected. Now they may be infected from other things. And I think the evidence that a mask wouldn't help you is relatively weak. But more importantly now, the reason to wear a mask, the reason for all of us to wear just a surgical mask, is to stop us spreading our droplets to others. And it is very effective for that. None of us know right now, unless you have had symptoms of COVID and been given a test, whether you have COVID or not. Many of us could be carrying this virus. And that's the logic now behind the order that came recently, or the recommendation that everyone wear a mask, is not so much to protect themselves as it was to prevent everybody from sharing their droplets when they talk or speak or come into contact with people. That's also the rationale behind the 6 days. So masks, I think, are good. I wear a surgical mask when I go get my groceries, and I think it's a good thing. Gloves, yes, that can be fine, as long as you dispose of them, take them off properly and so on. But gloves will protect you from getting the virus on your hands, but whatever you're touching with the gloves will have the potential to have it, and then you can transfer the virus if you touch other things with the gloves. So it's just an important thing to pay attention that, you know, if you are, for example, getting, one approach would be to maybe have a glove, use that hand for the door and the various things that many people in the public will touch when you buy something in the groceries or whatever. Use a clean hand or so on, and then, you know, don't cross contaminate or touch the glove to it. I don't wear gloves when I'm going, but I wash my hands rigorously after, and I try and avoid touching things. And so you see at places like Homeland, Target, and so on, they've been having staff with cleaner, like disinfectant cleaner, wiping the grocery cart handles and various other surfaces that people may touch, and that's good. The key thing here is don't touch your face. If you're touching something, don't then go and touch your face, because that's how you're going to inoculate yourself with the virus. If you do wear gloves, you have to take them off carefully and then wash your hands right away after doing that. Katie, a very good question. Could the pandemic stop without achieving herd immunity? Yes, we could bring this to a halt and a low number of cases, but there may still be many individuals who have not been exposed to the virus, who then may not have immunity to it. This is going to be one of the very important, and so you're right, quarantine and social distancing may not prevent it from resurfacing in the future on a pattern like the flu. In fact, that's potentially what might happen. This is where the antibody testing is so important, because we can, in the interim, we can test our population. We can do random samples and see what proportion have antibodies. Now, from your book and from prior discussions with Dr. Bratzler, you would know that, you know, when we develop vaccines, say as we were talking about measles, the proportion of the population you have to vaccinate to create herd immunity is equal to 1 minus 1 divided by the R0. R0 for this infection is about 3. That's a reasonable number to use. Might be a little bit higher. Let's say it's 3. 1 divided by 3 is, you know, 3.33, right? So 1 minus 0.33 would mean we would need to vaccinate about 67% of the population to create some herd immunity to COVID. Now, what do we do when we vaccinate? We vaccinate, we create antibodies. So if we go in and measure who has antibodies in our population, if that number is very low, 5 or 10%, we know that there's still great vulnerability to the infection among people who've never been exposed. If we saw that 50, 60% of the population already had antibodies, that would give us confidence that there's some herd immunity developing to COVID-19 in the population. So that's a great question, and hopefully we'll have a vaccine in between 12 and 18 months, but we may have to go through one flu season, that is November this year through March of next year, again, without definitive vaccine. The antiviral drugs are undergoing study very quickly, and there was a very promising report last Friday in the New England Journal of Medicine with a drug called remdesivir, which was developed back a few years ago for Ebola and for SARS, and they're trying it now for COVID, and they published some preliminary results which look quite positive, and there are about 10 different clinical trials now going on with this medication, remdesivir, which is a direct antiviral drug that stops the replication of the virus and interrupts it. But the virus could well resurface in the future for 2 reasons, because it may just do that on following a seasonal flu pattern, or if we come out of social distancing and sheltering at home, but if we then fail to control small outbreaks that happen, it could then regain a foothold and in the community, and then you see that upswing curve again of new cases, infection. So the strategy will be, if when we come out of the social distancing and quarantine, we'll want to monitor very carefully for any small eruptions of infection, and then test, diagnose, and isolate those individuals very quickly. How much worse is it going to get before it gets better? We're optimistic, as you saw from the curves, that we might be bending the curve downwards now. So we might be at the start of some improvement. That there will still be more deaths, because the deaths will lag the curve of new cases, because the people who are infected, the disease has to run the course, and of course it's the high-risk individuals. Okay, so number of deaths, number of hospital use in ICU could still continue to go on for a bit, but hopefully we have begun to see a bending of the curve and bringing that back down, and hopefully the broader quarantine, isolation, social distancing has been starting to be helpful. Now, Gracie's asking about the summer heat. That's a hope, but I don't think necessarily going to be the case. We might get a little bit of an idea of that for example, the virus didn't have too much trouble infecting Australia, which is in the southern hemisphere, although that wasn't in the middle of their summer. the height of their summer is right around Christmas time in January. So it was February, March, but it's not necessarily true that the summer heat will see a diminishing of this virus, or it may, and we hope that might be the case. The problem is exactly as you've outlined, Gracie. You know, if we don't have a vaccine for 18 months, and we come out of the quarantine and social distancing too fast, such that it resurges in a big way, then we might have to go back into that approach, and that's tragic with the impact it has. What we want to be sure we can do this time, let's say we get a downswing and we damper this down a bit and get that down to a low number of cases. We want to be sure in the fall, if we see a steady low number of cases when we come up to flu season, we want to be sure that we can test as much as we need and that we're monitoring closely for any people with signs of infection, and then we test all of their contacts, asymptomatic and symptomatic, and isolate those individuals. That's the only way we can be able to go ahead, and that would be minimizing the number of people who have to quarantine and social distance rather than the broad population. As I say, I'm hopeful, I'm praying and hopeful that a drug treatment will be available sooner. It's easier to get a drug available than it is a vaccine, of course. It's much more challenging to manufacture the vaccine, to do the clinical studies, and then to scale up production of the vaccine. The company that makes remdesivir, Gilead, has already announced that they were launching a scale up of production. So we might be able to have an antiviral drug like Tamiflu is for flu for this one sooner than a vaccine. Haley, a very good question. You know, hindsight is 2020. If the pandemic response team wasn't disbanded, would it be more effective at stopping the spread of the disease? I think a lot of people, you know, would like to make that argument, and you could probably, maybe it's hard to know, right? But what is clear now and coming out is that there were a number of individuals sounding the alarm of this fairly early on. The Chinese CDC spoke with our CDC director, who elevated that to the Secretary of Health, who elevated that to the President. The trade advisor, Mr. Navarro, wrote a long memo to the President outlining the devastating impact. He was predicting pretty accurately what was happening. The CIA was picking up information on their intelligence activities in China and advising through their channels. And the Defense Intelligence Agency was picking up information as well. So there were multiple sources of input coming in back in January and early February, which, if listened to and action had been taken, might have led to something quite different. All of that will be for historians and political scientists to argue about, why it didn't happen, all of those things. You know, there is a team of people advising the President, and different people on that team have different viewpoints, and they're all trying to make their points. And who the President ultimately listens to and makes a decision is not a simple thing. It's a complicated thing, and there are trade-offs. The Treasury Secretary doesn't want the economy shut down. You know, so there are people on the side of not shutting down. There are others who were more aggressive, focusing on the health outcomes and so forth. So it's hard to know. I think this will be something that historians and political scientists will study for some time. So Jill, your question here again, our flu season could have had traces of COVID before we knew it was in the US. Yes, indeed, that's what I was, I'll just bring that graph back up for you. And that's what we really were getting at here. Let me just see. Okay, so this slide, Jill, gets to your question that here, once the confirmed cases of flu by this time in March, here at the start of March, end of February, start of March, end of February, you see flu confirmed cases are going down and ultimately went down. But people with symptoms of the flu was not, that was increasing. And so that is COVID. It's possible that this circle could extend back further with some of these people also being COVID. In fact, it probably is because the incubation period is 2 to 14 days. And here you see an uptick in these situations. And you can look at the pattern of new cases. Here's new cases. They started ticking up really significantly in the US right here about the middle of March, right? The inflection point on this curve is right about here, maybe the third week in March or just before that second week, and you see it starts to take off. So it had to be circulating over here. In fact, it probably was because the number of new cases is starting here in early March, this virus was probably circulating around in early February in a community way. Good, excellent question. Jill, had the flu back in February, but was not normal symptoms. Shortness of breath, fatigue, and headaches were common for you. I had exactly the same thing. In fact, I'll use my personal example. Myself, my wife, and we participate in a dinner group with our neighborhood. And that dinner group goes to dinner. It's about 10 or 12 people once a month. And around the second week in February, second Thursday in February, we went to dinner at a restaurant in Oklahoma City. And we were sitting just directly across from another couple in our neighborhood. And within 48 hours of that dinner, the four of us came down with these kind of symptoms. Philana will know that it was a Monday when I left early to go home. I wasn't feeling so well. I hadn't done that in probably 20 years in my time at Oklahoma, but I was feeling bad enough that I just went home to rest and so on. My wife was in bed for almost a week and did develop some shortness of breath a little bit, but it went away. The other couple, the man, he rebounded very quickly like me within 2 days to 72 hours, but his wife was down for 4 or 5 days as well. I've never seen an infection, a flu or something like that, that would take out, 4 people like that. And so if you think we were having dinner at a table across, so we're well within the meter or 6 feet distance. So it's entirely possible that we had COVID. Now we recovered, we're okay, everything is fine. The only way for us now to know whether that's true or not would be to test whether we had antibodies. And if we have antibodies, then it would be likely that that's what happened to us. So I think this is interesting. Thank you for sharing that, Jill, because I have been talking to my wife and others and said, this is very funny. And also, I've never seen us get shortness of breath from the flu like this. You can do it. Some people more severe, but that was key. I know that Maddie, thank you for sending that. I'm going to do now that we're back up and running. The first couple of weeks after the spring break were very busy. But now I'm going to want to do more in-person Zoom chats with you, if only just to chat and talk. And I really appreciate this comment about easing stress. We shouldn't be afraid to talk about stress that we might be feeling over this whole situation. And if any of you are, I encourage you to speak with the counseling team on the Norman campus or the health sciences, but also I've been talking with Valana, and I would like to do now some more Zoom interactions with you as well, in addition to the pre-recorded lectures that I'm putting up there. So yes, I think let's ask the students if they, we will look into posting a recording, Catherine. I think we can do that. Yes, you can share. I would like to know, and you can either answer now or you can email us, what is going well for you or not so well with this transition to online. And if you have suggestions for us, we still have 3 weeks or so to go in the semester here. There's things we might be able to do to help you work through the year. Let us know. We want to work with you. You've all been, all of my students, and I want to congratulate you all and thank you for being so understanding and thoughtful. I know it's likely to have been very difficult for many of you, a big change in your life and how this works. And I just want to make sure we continue to bring you education. And so we will do a couple more chats at least, probably. And we want to hear your suggestions. Okay, a great comment. Blocking out time to do schoolwork and setting boundaries at home for school has worked very well. Those are two really great points. Those are things that people who telecommute in business also understand, right? Because when you're home, there are a lot of interactions, or family who are not necessarily not well-meaning, just want to interact with you or whatever, and distract you from doing school. So those are great suggestions. Block out time and say to your family members, during this time I'm focusing here on school, please don't. And then when I'm done that, I can engage with the family and do those kind of things. Jill, better in libraries and coffee shops. Yes, because your parents are working at home as well. So that is a challenge. These are things. If you have a space, an office of your own or something like that, that can sometimes help. But I understand the impact this has. Please do share other suggestions, though. Coffee shops are closed, yes. I think also it's important to know when we come out of the shelter at home or the social distancing, it's not going to be just like flipping a light switch. It's going to be more like a phased transition to make sure that we don't get back into accumulating new cases. Carrie's having similar kind of challenges to this. I'm with you. I do a lot of work at home, and sometimes there are interruptions. My wife wants to do something or speak, or the dogs are bothering me or on me. So it's important to try and block some time and have some space. Weekly communication, great. Let's do that. We are trying to post regular messages for you. Please check Canvas regularly. We'll continue to do that. And I think we'll like to have a couple more of these sessions before the semester is finished. Right. I understand when you're having to look at all your courses on Canvas and self-manage your deadlines and all of those things. That's important for us to keep in mind. So those are all good suggestions. Very good suggestion, Reagan. That don't work in your bedroom or bed. Try to have a different room so you can kind of create a feeling of a difference between what's work and what's home, even within a small apartment. And that's a very good suggestion, and that would be consistent with what a lot of the professionals who consult on this would advise. Again, even in the kitchen, slightly different environment. opening windows, sunlight, very good things. As long as people aren't talking in the windows to you within 6 feet, that's important. But yes, windows and sunlight is good. I know that having a sunlight is really uplifts my spirits very significantly. Thank you, Gracie. We're trying very hard to do that. Let us know. Don't hesitate to check in with us anytime. You know, this is a learning experience for me as well, and it's been very challenging as well. So we'll continue to try and communicate. And if you're having issues with Canvas, do please let us know. Valana's been a superhero daily working on that Canvas and making sure everything's functioning there. And let us know, because that's critical to us effectively communicating with you. Are there any other questions? Okay, if not, thank you very much. I will let you know that I'll be posting up some, a quiz grade dropped. As it said in the syllabus at the beginning of the course, you know, we'll automatically drop your worst quiz, the worst grade, okay? So that's at the end, once all the quiz grades are known, the one that is the worst quiz will be dropped. Now, if you have a very good grade all the way through, and you know, don't think you're going to improve it more, and you don't want to take the last quiz, that's what some students have done in the past also. But it's based on the total number of quiz. Valana, thank you for clarifying. You know, if you missed a quiz and just didn't do a makeup, then that's going to be your worst grade, so we would drop it. But if you do all the quizzes, then your worst grade will be dropped. I think the class is doing very well. Try to take, if you can, have time, take advantage of 1 or 2 of the extra credit opportunities. They're there for your opportunity to add a couple points directly to your final grade. Okay? Excellent. Well, thank you all. I wish you a great start of this week. As I said, we'll be posting some more material, and we will we'll be back with you with more of these interactive chats, at least a couple more of these, I hope, before the semester ends. Good luck, thank you, and don't hesitate to email us if you have questions or suggestions. Thank you for your comments. Have a great evening.